right. Well, good afternoon, everyone. Thanks for joining us again this Friday for our Friday webinars, where we're working on just making sure that we educate folks on things that are happening. This topic is a bit more complex, so we had to go with Sarah Van Gertruiden. Sarah is, I don't know if she's a Louisiana native, but she worked for members of Congress from Louisiana, Senator Breaux, and then with Patton Boggs. She works in the patient advocacy community as the executive director of the Partnership to Improve Patient Care. So without further ado, I'll just go ahead and turn it over to Sarah.
Thank you. It's really exciting to be here, and thank you to the National Minority Quality Forum. You always do such a nice job of putting together these kinds of educational opportunities. I know I'm actually excited to hear the presentations because this will be good for me too. But I want to also just briefly introduce Jessica Negra, who is the Director of Advocacy and Strategic Alliances at PhRMA. You know, she's actually really great at this too because she comes from a patient advocacy background from National Psoriasis Foundation, and also having worked at the Dialysis Patient Citizens Group and with Elder Care Workforce Alliance. So really appreciate that you're here, not just to bring the industry perspective, but that you have this great patient background as well. And also Courtney Christian, who is the Senior Director of Policy and Research at PhRMA, who also, prior to PhRMA, worked at the Black Women's Health Imperative as the Director of Policy and Advocacy. Both of them have tremendous Capitol Hill experience as well. So no, not just the policy, but the politics, which as we all know is just as important. So I want to just say thank you guys for being here. Thank you for taking this opportunity to run through these important issues with us. Just, you know, to level set, just as I think everybody already knows, we're going to be talking about this CMS Medicaid benefit and policy parameters rule that came out, as well as some pharma equity initiatives. I think it's going to be a really nice opportunity for us all to learn and to ask questions. So when this is over, there's actually going to be a poll question too that we'll put up on your screen, and are excited to learn more. So thank you. Jessica, why don't you go ahead?
Great. Thank you so much, Sarah, and thank you to NMQF for inviting me to speak to you all today, and thanks to all of you to take an hour of your time on what looks to be a rather sunny, although potentially a little sticky DC Friday afternoon. So as Sarah mentioned, I'm going to go over a new policy that was proposed from the Centers for Medicare and Medicaid Services that sort of on its face has to do with some changes to the Medicaid program. But I think I'm going to go through a couple of proposals that I think are actually a little troubling and could really have some profoundly negative implications for patient cost sharing for patients far beyond just the Medicaid system. So if I can get my tech to work properly, I'm going to share some slides here. I want to do these just so that, let me see if I do it this way. Just so that sort of as a tool to help us walk through what I'm going to be talking about. But I'll try to keep things conversational. As Sarah mentioned, please feel free to chat questions in. I'm going to do a quick overview of what's in the rule, and then certainly I want to make this a discussion for afterwards. So as I said, this is a Medicaid rule that was proposed just about 3.5 weeks ago now. But unfortunately, it includes a couple of provisions that will have implications far beyond the Medicaid program. And one of them that I'm going to really drill down into now, we're sort of talking about as another piece and sort of what seems to be this administration's interest in chipping away at manufacturer assistance, at copay coupons, at the kinds of programs that drug manufacturers set up to help people afford their drugs at the pharmacy counter. And so this and another policy that I'll sort of touch on are part of a worrying trend to sort of, as I said, undermine or limit or chip away at this assistance that our manufacturers really provide to help patients afford their drugs at the counter and help people maintain adherence to critical therapies and live, you know, healthy and happy lives. So if you missed the news that CMS had released a proposal that undermines cost-sharing assistance, you wouldn't be alone. Even we at PhRMA were very caught off guard when we saw this notice of proposed rulemaking that was released on June 17th. You can see here at the top is the sort of long, formal, technical name, but I just raise it because they sort of talked about this and build this rule as a value-based arrangements or value-based purchasing rule. And there is part of that policy changes in the rule itself. But as I mentioned, there's a couple of other pieces that didn't get the headlines from CMS. You can see their press release title here, where they don't really even mention it, but we think are really critical, and I really appreciate the opportunity to talk with you all about them today. I will flag here in red, unfortunately, Medicaid only gave us 30 days to comment, and with the 4th of July, it was even sort of fewer working days than that. The deadline is Monday. At the end of my slides, I'll give you a couple of ways that you can engage if this feels like an issue that's relevant to you personally or to your organization. I'll give you a couple of easy ways that you can get involved in addition to just sort of writing your own comments before Monday and getting them in. So I want to flag here, there's a couple of key issues with the proposal. A line extensions definition change, value-based arrangements, and reporting to best price. This one that's highlighted, the copay coupons and accumulator adjustment programs and the change to best price, is what I'm going to drill down on today. But if you have questions about any of the rest of these pieces, I would be more than happy to talk about them during the Q&A, and I'm happy to sort of walk through what we're thinking and how our comments will reflect some of the changes here. But before I sort of dive into exactly what it is that Medicaid is proposing, I want to just quickly set the stage. I'm going to use a couple of really technical words that a lot of these are sort of new definitions to me even, and I want to just make sure that I'm being clear about what we're talking about and make sure that we're all sort of on the same page. So many of you may have heard of new insurance benefit tools used by commercial insurance. If you have employer-sponsored care, you might have one of these in your health insurance benefits. It's called an accumulator adjustment program. It's a very technical way to describe a new policy where insurance companies are increasingly blocking the amount of manufacturer coupons that our companies give to patients. So if you have a copay coupon, if anything sort of that your drug company gives you to help you with your cost sharing, insurers are blocking that from counting towards patients' out-of-pocket maximums, maybe your deductible if you're in a high deductible health plan. So they're still taking the value of that copay assistance, but they're no longer allowing it to count to meet any of those cost sharing maximums or limits that you need to reach. This is a really worrying trend. Our manufacturers provide this assistance to help patients. It is not meant to go to health insurance plans or any middlemen in the system. And we have seen a proliferation of these accumulator adjustment programs in insurance policies over the last sort of 5 years or so. Unfortunately, just this May, HHS released a different rule. You may have seen that the 2021 Notice of Benefit and Payment Parameters, or NBPP as it's often referred to. That reversed a policy that had prohibited insurance companies from using these accumulator adjustment programs. Just last year, HHS had said that insurers have to count the value of this assistance towards maximums and deductibles. But this spring they decided to reverse that. So now HHS has sort of given insurance companies the flexibility and the permission to expand the use of these programs and limit the value of manufacturer assistance. Switching gears a little bit to the Medicaid program, I just want to flag that I'm going to talk about Medicaid best price. It is what it sounds. The Medicaid program is guaranteed, is required to have the best price in the market. They pay the lowest amount for drugs regardless of the drug. And it is Medicaid best price is sort of a complicated equation that I won't get into and sort of isn't important at its core, but I just want to flag that it's a term I'm going to use. And key for this policy is that right now, these manufacturer assistance programs, these copay cards, these coupons are not included in the value of best price. When our manufacturers sort of calculate what it is that they're going to quote unquote charge Medicaid, the value of this copay assistance is excluded. So I think sort of if you take nothing else away from this presentation, this bottom bullet here is really what I want to stress, and that's that this proposed change that I'm going to get into the details of right now is really another way that HHS is proposing to undermine the value of assistance. And I'm sure many of you, either personally or know of a family member who relies on copay assistance, who works with a drug manufacturer to help afford medications that they need. And we really think that this policy has some troubling implications. So what does this policy do? So the new proposed rule requires manufacturers to ensure that the value of any cost-sharing assistance that they provide goes entirely to patients. It means it's now a requirement for manufacturers, for drug companies, to ensure that none of the value of those copay cards goes to an insurance plan. You can imagine from what I just talked about that this year's 2021 NBPP now allows insurance companies more flexibility to take the value of this assistance and not count it fully towards patients' health requirements. We're going to say infeasible because our attorneys won't let me say impossible, but it is on a practical sense impossible for drug manufacturers to guarantee that the insurance companies aren't taking some of that value, in part because HHS is allowing them to. Just a couple months ago, HHS said this is okay, you can do this now. I'll note that insurers not only can use these AAP sort of programs, but they're actually under no obligation to disclose either to drug manufacturers or frankly to the patients enrolled in their plans that this is what they're using. So there's even a fewer or less transparency than one might think in this system. And what happens now, since HHS is now proposing to make this requirement, but it's basically a requirement that there's no way that our manufacturers can meet, is that the value of this assistance now has to be included in the calculation for Medicaid best price. As I said before, the Medicaid program has to receive the quote-unquote best price in the market. And it's really a market driver that is, because of the requirements are so stringent and because of the impact it has on the rest of sort of drug pricing, quote-unquote, in the market, to add the value of this assistance in will really artificially lower that price and really change how our manufacturers look at the ability to offer manufacturer assistance. And it's really unfortunate. I hate to sit here and sort of cry wolf, but if you think about how large the Medicaid program is and how significant a reduction this could be, we really worry that many of our manufacturers might have to start to think about how much assistance they're able to offer in the future, what kinds of assistance, and there might be a restructuring and potentially a pulling back of manufacturer assistance due to what seems to be sort of a behind the scenes math calculation for how this assistance counts for patient, for the Medicaid Best Price program. I just want to make this a little bit clearer because I know I've sort of talked about two different proposals here and they get very complicated. So it's this 2021 NBPP that you can see here on the left-hand side that allows insurance companies and middlemen, if you've ever heard of PBMs, to exclude the value of cost-sharing assistance or not count the value towards patients' out-of-pocket limits. It's allowing insurers to sort of take and keep some of the value of the coupons that and copay assistance our manufacturers provide. This new proposed rule is now saying that unless manufacturers can ensure that all of the value of that assistance goes to patients, it now has to go into the Medicaid best price and AMP calculations. So you can see that these two sort of run counter. HHS is saying, we're going to let insurers do this, and then they're going to put manufacturers on the hook for rating this in. So this is really what we see here at the bottom as the unfortunate patient ramifications for this policy. It could reduce access and adherence for therapies for the millions of Americans who rely on manufacturer assistance. And I'm going to stress here, and I'll probably repeat myself in a second, but patients in the Medicaid program are not allowed to use coupons. They have very low cost sharing usually. Coupons are not allowed in Medicare or Medicaid. So what you're really doing is by making this change to a Medicaid pricing reporting requirement, you are negatively impacting the ability for commercial market patients, for those who get their insurance coverage through their job or through an ACA marketplace. They're the ones who are going to be impacted. We have a lot of issues with accumulator adjustment programs in general. We think the value of the assistance we provide should stay with patients and should not be allowed to be taken by the insurance companies. And so we're worried that this policy furthers the sort of misguided use of these policies that harm patients. As I mentioned, this is a major change to the Medicaid program that impacts patients in the commercial market in a way that I think many people aren't aware of. You know, even we looked at the Medicaid rule and thought, oh, okay, well, this is going to go into our sort of Medicaid work stream, and then realized quickly about the implications for this rule outside of the Medicaid program, and that this was a bigger deal than sort of how it had been framed. And at the very least, it does Also nothing to expand access, reduce costs, or improve care for the Medicaid program for people who rely on Medicaid as a vital resource for providing healthcare for low-income individuals. CMS doesn't say how this will help any of those folks. As I mentioned, so I'm happy to take questions. I know that's a lot, and it's a lot of different moving pieces in terms of accumulator programs and notice of benefit payment parameters, and I'm happy to answer clarifying questions or go into more detail. But just in case this is something that resonates with you, that you have, you rely on copay assistance, you work in an organization where your patient community or provider community relies on this assistance as well, I wanted to flag quickly a couple of ways you can get involved. As I said, the comment deadline's Monday. I encourage you, I'm happy to chat with you and provide some more resources. If you want to write your own letter, you can submit it on regulations.gov and you can weigh in. If that's not something you can probably do or your organization can do between now and Monday, the Chronic Care Policy Alliance has a great comment portal. I can share the link to that, and it's a way that you can sort of fill out your information. You can add your personal story in and hit submit, and they'll send the letter on your behalf to CMS. There are two great national patient organizations, the American Autoimmune Related Diseases Association and the HIV and Hepatitis Policy Institute, that are leading an organizational sign-on letter. So if this is an area that you think your organization would find important and wants to weigh in on, that letter is open for groups to add their name. That will close Monday right around lunchtime, and I'm happy to share the link to sign up and the letter and put you in contact with Randy or Carl, who lead those organizations. I'll also flag really quickly, just yesterday, Congress introduced legislation to push back on this 2021 Notice of Benefit and Payment Parameters that allows the expansion of these harmful accumulator programs. It's a bipartisan bill. It was introduced just about 24 hours ago. And so if that's something that you are interested in learning more, let me know. But I'd certainly encourage you to call your members of Congress and urge them to help out. Here's my email address. Feel free to follow up with me directly, or certainly anyone at NMQF can connect you to me. That's my presentation. I appreciate everyone's time. And I'm going to now turn it over to my colleague, Courtney Christian, who's going to talk a little bit about what we at PhRMA are doing in sort of this new environment. So Courtney, let me stop my share. Okay.
Thanks, Jess. Bear with me just a moment, folks, as I figure out how to share my screen. Okay. All right. Thank you all for having Jessica and I here with you today. We really appreciate, the invitation from NMQF to speak with you all today, and to really share with you the things that PhRMA is working on from a Medicaid perspective, and also in our industry's approach to equity. And so I think we all know, I'm going to apologize in advance for, a 4-year-old that might photobomb us all. He's discovered Zoom and it's his new favorite thing. In this new time in which COVID is really sort of holding us all captive. We've also had some time to really sit at home and watch sort of the confluence of COVID-19 really spotlighting the longstanding health disparities that we all have seen and known about and studied, and really sort of the confluence of that and the long-going, centuries-old fight for racial justice and equality that really got spotlighted even more with the murder of George Floyd. I think the confluence of those things together has really had our leadership within PhRMA thinking about what our industry response should be, both as a trade association and as an industry. So we've been asking ourselves, interrogating ourselves internally, what more could PhRMA be doing in this space? And so we've been thinking in terms of, where we could move next. Our most recent efforts include adding, consultants like the HBCU 20 by 20 group to consult with us on finding, pools of diverse candidates to add to our talent pipeline, both within PhRMA and within the industry. Thinking about our recent hiring efforts to increase diversity, including, having more female representation and, of course, cross-section of minority representation. So we've retained some groups like the Raven Group, like Meridian Solutions, and some other sort of new to us firms to help us be thoughtful in how we can amplify those efforts to decrease our pool of talent coming into our building and across our industry. And then we're thinking, you know, along the next 3 months, where can we do better in, you know, setting supplier and diversity goals in our future contracts and future, you know, requests for proposals. We are internally having our own sort of staff discussions and events on diversity and inclusion and sensitivity and implicit bias in the workplace and in events like that. And then we're trying to figure out and be thoughtful about where pharma can engage across, you know, partner boards, so that we can really be a real partner in the effort to, you know, both address health disparities that have been highlighted by COVID, but also be thoughtful about how our industry can be a lot more inclusive. And so, you know, as we've been having these conversations internally and externally, you know, with our member companies, we've had some focused voter group meetings. We've heard, you know, very directly that anything that we do in this space, you know, has to be authentic. It can't come across as a PR campaign. And that's important to us too, that it does not, that whatever we do really represents, you know, a culture shift in the way that we do business, both as a trade association and as an industry. That what we do is transparent, that it really is not a retread of sort of old ideas, that it really represents out of the box thinking to really meet where we are in this moment, very historical moment in time. And that it's, you know, relevant inside and outside the Beltway, you know, in places like my hometown in Tallahassee, that it really resonates, you know, to everyday Americans and not just sort of DC insiders. And so what we're thinking is sort of incorporating some new programs into existing programs into new initiatives that kind of follow a few buckets around, you know, what we can do as employers and employer-based initiatives, what we can do to address, you know, health disparity, moving from disparity to equity, and then sort of what our companies are already doing that we could mirror and hold up and use as learnings for other industries to mimic or replicate. And so, you know, we have a variety of programs that already do some of this good work. We have a Roadmap to Health program that is a mobile health program that goes into underserved communities and does, you know, sort of health diagnostics, kind of trying to, you know, partner folks with the medical community close to them so that they can get the assistance they need. We have a STEM talent pipeline program around the country in which we issue grants to certain schools to try to, you know, get kids interested in the maths and sciences early and sort of, you know, direct them into science-based careers. We have our health equity roundtable that really looks at policy solutions to fix health disparity issues. And then we have our medicine assistance tool where folks can go online and look for, you know, patient assistance from member companies and other resources to pay for their medicines should they need that help. So as I said, our sort of 3-pillar approach that we're taking as we think about equity as an association and as an industry is looking at our employer initiatives, you know, committing to do more in our support of minority-owned businesses and our supplier and procurement practices, thinking more thoughtfully about our STEM commitment from grade school to graduate school. You want to try to catch kids early in the process, more towards elementary school and instead of, you know, waiting till middle school or high school. We want to really be thoughtful about what we do to enhance clinical trial diversity. We know when we have more diverse participants in our clinical trials, we get better results, and we know what is most effective for certain patients in certain communities. And then we want to be thoughtful too about a new commitment to, you know, addressing health disparities and social determinants of health, which is, you know, sort of out of our wheelhouse, but we're really thinking like this moment in time really requires us, you know, again, you know, displaying out of the box thinking and getting out of our wheelhouse to be more effective. And then we also want to, you know, think about where our company commitments are, aggregate things that our companies are already doing. A lot of our companies already have programs along these lines, along employer initiatives around health equity, around clinical trial and diversity. We really want to be able to sort of compile that and figure out best practices and what might be, you know, great going forward or things that we could scale up that would make more sense for us to coalesce around. And you know, sort of undergirding all of this is, you know, this sort of underlying principle that diverse teams are essential to developing new medicines for all patients who need them, and that, you know, our biopharmaceutical companies are really intent on being part of necessary, positive, and long-term change. And so with that, I think I'll turn the discussion back over to Sarah. You all will be, you know, hearing more about this as we go along and develop our plan in the process. But we appreciate hearing from all of you and the things that you think that we could do better to be better corporate partners in this space, and just to be better in the communities that we serve.
Thank you so much, Courtney. You know, I will say, you know, as we go into questions, and please feel free to use the chat box to submit questions, but the Partnership to Improve Patient Care, of which I'm the executive director, our chairman, Tony Coelho, also is the author of the Americans with Disabilities Act. And during this whole COVID-19 crisis, you know, we've been really focused on the discrimination that's been happening across the country. And I think it's uncovered a lot of challenges. But I really appreciate what you were saying, Courtney, because it's so important. And, you know, getting over a lot of this is going to require it's not just about what we do now, but it's also, like you said, creating this pipeline of professionals that are in the system that, you know, more STEM, more engaged advocates, you know, more people from minority communities and, you know, disabled communities, et cetera, participating as doctors and nurses and in the system. And so anyway, I appreciate everything you were just saying. I think it's really wonderful, and I'm so glad to know all about it. I didn't know how much PhRMA was doing, so that's fantastic. So my head is also swirling with a lot of questions for Jessica around this rule, because this is all really interesting to me, especially. It would be helpful to better understand how the proposed change to the Medicaid program is also going to impact individuals who get their health coverage through their jobs or through the ACA marketplaces. Help me understand that.
Sure, that's a great question. You know, I think that, as I sort of said, you know, we looked at this, it's a Medicaid rule. This is just going to impact those patients who receive their care through Medicaid. But unfortunately, because Medicaid patients themselves don't have access to this cost sharing assistance, they have a different way that they have reduced payments at the pharmacy counter. It's really the patients who get their coverage through their employer, or as you said, an ACA marketplace, or if you have a short-term plan, or even sort of a health ministry plan, anything that's sort of not a government health program. They're the ones who really rely, many of them, on this assistance. And they're the ones who are going to see if, unfortunately, our companies are required to sort of change how they offer it or how much they're able to offer, or have to make any of those hard choices. It is going to be those patients in commercial plans who will see the impact of this, and not those in the Medicaid program who will sort of be shielded from many of those changes.
That's helpful. Oh, another thing, while we're waiting on some questions to come up, you mentioned in the rule includes policy changes around the definition of a line extension. Can you explain what a line extension is, and what that proposed policy change could do? I would appreciate that.
Yeah, absolutely. So I'm not a Medicaid policy person. So honestly, I didn't know that the words line extension fit together until 3.5 weeks ago when this rule was released. So it's been a bit of a steep learning curve here, but sort of to boil it down, the Affordable Care Act actually made a policy around what it calls a line extension. And it meant to kind of curb, you know, I'm sure some of you have heard, you know, manufacturers who sort of make one small tweak. They change the color of a pill, or they change the size of a pill, and it doesn't really have any sort of clinical benefit, but they make a change to it and call it a new drug. And therefore get a sort of difference, get a better Medicaid best price, so to speak. The ACA wanted to cut down on this sort of gaming of the system by making small changes to drugs and calling them new, which has been in place for 10 years and is working very well. Unfortunately, what this new proposal is doing is it wants to take that definition of a line extension and blow it up. So it's no longer just small kind of cosmetic changes. It's now going to include anything like if it switches from a pill to an inhaler or a patch or a long-term injection, if it switches to a combination therapy, if it switches to something that has a longer, long-acting, all of those will now be called line extensions. And again, it relates to the sort of best price reporting. So it gets a little bit technical, but I think the sort of crux of it is what was meant to be a policy that would sort of trap the bad actors in the system, that would prevent manufacturers from gaming the system by claiming innovation when it's not innovation. This is now really going to harm innovation. It's now going to mean that when drugs come to market, any improvement that a drug manufacturer makes to it will now mean that the drug manufacturer owes more money to the Medicaid program. And certainly we believe that Medicaid should have access to the best price. We're not suggesting that that policy is wrong, but we want to make sure that we're not inadvertently disincentivizing innovation by claiming that what was meant to sort of rein in small tweaks now could really harm what patients rely on for sort of innovating and tweaking and improving upon medicines. And I'll give one quick example because I know it's a little hard to kind of think through what that would mean, but our boss is a doctor, and he often talks about the fact that for a while, a lot of migraine therapies were given via pill. Mm-hmm. And they switched that to a patch because for a lot of migraine patients, they have nausea and they can't keep down medicine. And so what I think everyone on this call could recognize that that's a real innovation and that really improves patient care. That would now be classified the same way as making a pill purple because purple is more appealing. And so we just think the definition is really broad and could be really harmful in a way that the system is working right now. And we're okay with sort of keeping the bad actors in a different bucket than really what innovation really means.
Okay, that's helpful. That's a good explanation. So I know when this all first came out, I was actually paying the most attention because PhRMA has been so focused on the concepts around value. And that's sort of what we've been working a lot with National Minority Quality Forum on. But so this rule is about value-based arrangements, which it sounds like it's about a whole lot of other stuff too. Then where is PhRMA then in terms of the value-based arrangement pieces of this proposal?
Yeah, great. As I said, that was sort of what the administrator talked up, and is a really key part of the rule. And we are really pleased to see CMS is working in this area. We think that there's a lot of different and really innovative ways that drug manufacturers are working with insurance companies to make sure that patients are getting good value out of the therapies and that people aren't sort of if there are drugs that aren't effective for individuals, that we're sort of not putting people in unfortunate situations. And so we are, as I said, really pleased and encouraged that CMS has put forward some proposals to help encourage value-based contracting, innovative payment models. We think, unfortunately, the rule sort of leaves us with more questions than we have answers. So we're going to be submitting comments that have a lot of sort of needs for clarification and needs for additional information. We're worried that the proposal is a little bit too narrow, that a lot of the sort of really innovative ways that our manufacturers are working with insurance companies might be sort of left out in a way that I think even CMS wouldn't agree is the best path forward. So we're excited that they're working on it. We're excited to see that this proposal move forward, but we do have a lot of questions that we're going to be asking of CMS, and hopefully they can give us some good information and we can make sure that this moves forward in a way that sort of helps everyone involved.
So I'm curious, I know when I started this, I mentioned that there was going to be a poll question. So I don't know if we can pop that up, but I think the question is, and this is, I think, a fascinating question is, have you or anyone you know ever used a copay card or drug company assistance when accessing your medicines? It'd be interesting to know, just out of everybody that's here, the extent to which folks have used these benefits or discounts, and that way we have a little bit more of an understanding of how many people on this call might be impacted by these policies. I know I have. We'll give everybody a minute. Oh, good, look. So now we can see how this is turning out for us so far. Well, it's interesting that so many people have used it. I know I've used it. I used it once for an EpiPen.
Yeah, I think, I wish I had this stat. I probably have it somewhere. I don't know how many of our manufacturers provide assistance, but I think from what we've been sort of talking about with most of our companies, the vast majority do, and like to, they're happy to provide that assistance. And so I think any sort of policy change that limits their ability to do that, or limits the ability for it to really benefit the patient who was the intended beneficiary is troubling. So. But that's really helpful information. Thank you all for answering that question.
Yeah, no, that's great. I mean, I think it's, you know, that does sort of underscore then how important this rule is, and for folks who want to weigh in. You know, I found it interesting, I think what you said about wanting to make sure from a company standpoint that the benefits are going to the patient and not necessarily the middleman, because when you don't count these benefits towards people's copays, the beneficiary really then just becomes the insurer. So that's really interesting, and that's helpful context for why people need to be engaged and involved. So we also have a question that has come up on the chat room, and Courtney, this one looks like it's going to be more for you. So this is, it says, not hiring out of college. Oh, okay. So some companies that may not hire right out of college, and so they don't do the college fairs. Connecting directly with HBCUs doesn't make sense for that reason, and because many great African-American job seekers do not attend HCBUs, but African-American Greek organizations have annual conventions, and it would be a great place to seek new employees. Would PhRMA consider this strategy? That's interesting.
Yeah, thank you for that question, Valerie. I think we're really, thinking about all the ways in which we can touch, where we can touch folks. And bring them, into the fold, so to speak. I mentioned the HBCU 20 by 20 Connect program. Their platform is really based around bringing kids who just graduated from HBCUs into the corporate sphere. Realizing that they're, starting at the bottom, so to speak, to get to the top. But we're also, being creative about other places we can go. You raise an excellent point. Our Greek organizations are great places to find talent. And so we're really being thoughtful about all the ways in which we can make different touch points in different places to be able to bring people into the pipeline.
That's great. So just because Courtney, because I've got you up, it says another question that has popped up is, there are community organizations which are supporting the diversity pipeline, and how do they connect with the resources from PhRMA?
So I think one way that they can connect is, to contact us directly. At our Alliance department that, Jess is a fabulous member of, we have, those sorts of touch points with a number of, community groups that we make those connections through. So, just reach out to us. I know PhRMA, we also publicly, post our employment opportunities. So that's another way to sort of make that touch point as well. But in terms of making that sort of community connection, our Alliance department is the best touch point for that.
Good to know. And we'll probably, I'm sure, share information about how to do that.
Absolutely.
Okay. So Jessica, back to you. I have a question. Has AARP weighed in on this rule?
Great question. I don't know. I'm happy to take a look and see if they have done anything formal, or if we have some contacts over there, if they're going to be weighing in. And I'm happy to make sure that NMQF gets that information and can share it. But I haven't yet heard of anything public, but that doesn't mean that they're not in the works, since we have until Monday to submit comments. A lot of groups sort of get things in just before the deadline. But I'm happy to follow up with that and see if we can get some more information.
Great. And so another question that that's come forward is, what organization waved the banner for this major change to increase the wealth for insurance and PBMs, and in turn harm the community, the commercial community. So basically, I think the crux of the question is, where do you think this rulemaking came from? Like, who's pushing for it?
Yeah, I think unfortunately, at least the rulemaking from a couple of months ago that sort of allowed insurance companies to do this, it was insurance companies, and unfortunately a lot of large employer groups weighed in, asking for this. They call it flexibility, which I feel like has become the dirty word in healthcare the last few years of we want more flexibility, but that rarely means that patients see a benefit at the end of that. So the sort of argument for accumulator adjustment programs is that they help sort of insurance companies reduce costs elsewhere. They can sort of take a little bit of this money, they can hold down premiums, or they can rein in costs. We think it's a really short-sighted argument, if it's even true to start with, and I'm not sure that the data would hold that up. But you're sort of reducing premiums at the expense of the health of your employees. If they can't, access the medicines that they need to manage chronic conditions, to manage chronic pain, they're not going to be, productive employees. They're not going to live healthy lives. And so I think you'll see some downstream, additional healthcare costs if you need to be hospitalized and the like. But I think because of how we sort of do these cyclical one-year health benefits, it's easy to think in short-term numbers instead of long-term health. So it is the insurers and the large employer groups that are interested in being able to implement these policies, that I think it's hard for them to wrap their heads around the sort of downstream effects of this that could be negative for patients. But we are doing a lot of outreach to them. I know of another patient group that is doing a webinar actually with HR professionals just next week to sort of walk them through what these programs are, so that when it comes time for them to pick the insurance plan for their company, they have a sense of what it is they're really picking and what choices they have. So we are doing a lot of outreach to make sure that employer groups are sort of fully informed so they can make a really smart choice for their employees and not just sort of go what might be the kind of lowest common denominator for pricing.
Well, especially now of all times when people are struggling so much, it just seems illogical to put this forward.
Exactly. Yeah. And the bill that I mentioned that was just introduced, that's sort of the message, is that right now during this pandemic, when people are struggling in so many different ways, now is not the time to further compromise the ability for people to access healthcare. And so that the bill actually just asks for a delay of these policies until after we have tackled COVID-19 and are back to a bit more normal, when we can then think through, is this really what we want? But it would sort of mitigate some of the short-term implications that could exacerbate the challenges people are already facing.
So another question has popped up into the box. Has the general population been apprised of this change? And if so, how much notice was provided, and what types and how much outreach has been conducted?
So this went public, I think it was June 17th, so a month ago today. CMS unfortunately only gave people 30 days to formally comment. Usually they give 60 or 90, especially for a policy change that's this large. So we are disappointed that it's such a short time period, because we want to be able to provide thoughtful comments and do a lot of education and make sure people know what's happening. This is just what's called a proposed rule. So we have 30 days to comment. We have until Monday. CMS is actually required to read every comment. So they're going to have to go through, read them all, and then they will incorporate feedback. They might make changes. They'll decide to not move forward with some policies and change others. And then they'll have to release what's called a final rule. And that's when the policy is enacted. Right now, this is just them putting forward their idea of what they'd like to do. And then it'll be a few months down the road before this is finalized and formalized. And so the comment period is really critical so people can raise concerns and ask questions, because CMS does have to address them all as they move forward in their process.
Great. And you mentioned in your comments about a bipartisan bill that had been introduced. Somebody is asking who introduced it. Do you have like the bill number and everything?
Yes, I literally got the bill number right before this call. So let me scan my email here. So it was introduced by Congressman McEachin, who's a Democrat from Virginia, and Congressman Davis, who's a Republican from Illinois. It's a House bill, so it's HR 7647, and it's called the Preserving Patient Savings on Drug Cost Act. It just was introduced yesterday afternoon, and so I think a few other members of Congress have already signed on to support, but if that's something that sounds of interest to you all, I'm sure your individual members of Congress would be happy to hear about the new effort.
Great. And so somebody else is asking about the sign-on letter that was described earlier for other organizations to sign on. I know I'm familiar with the ARDA letter, AARDA letter, but maybe is it possible to provide that link to everybody for folks to sign on?
Yes, I don't know if I can put it in a chat, if it goes into the chat box, or I'm happy to make sure NMQF has it if they want to send it out as follow-up. Yeah, that there's another sort of 24 business hours until Monday afternoon to sign on. And so I know ARDA and the HIV and Hepatitis Policy Institute are encouraging as many people who want to weigh in. There are, as of this morning, more than 70 different groups that have signed on, and it's across chronic disease, cancer groups, groups that represent providers, doctors, and nurses, as well as people in the disability community, and a variety of others who sort of care about preserving patient access and reducing costs where they can. And so I'll make sure that gets around to NMQF so that they can share it as well.
That would be great. And somebody was just wanting to clarify, it is HR 7647, correct?
Yes, that's correct.
Got it. And so another question, what has been the response to the rule from the patient advocate community? I guess we know we have a letter, it sounds like, that's being circulated. I mean, I would imagine right now during COVID-19, it's so hard for people to have the bandwidth to be super, and how do you do that in this brave new world, right? So yeah, I mean, but has there been a lot of response from the patient advocate community?
Yeah, there's definitely been a lot of interest in this and a lot of activity. I think, as you mentioned, the sign-on letter is a great way for groups to sort of get involved and show strength in numbers. I think there's a lot of groups I talked about a lot about the copay piece, but there's a lot of groups, especially in the HIV/AIDS community, where the line extensions component, that definitional change that would impact innovation, is critical, because so many HIV medicines are compound drugs, and that would now be included in this. So I think that there are different groups that have sort of been focusing in different areas, but from everyone that we have heard, there's a lot of concern that this is moving forward, that this isn't sort of the right time, that even, as Sarah mentioned, the value-based arrangement part is really interesting and really exciting, and there's just sort of not a lot of time to digest it. So I do think quite a few groups are going to be weighing in either collectively or on their own, and I think hopefully CMS will take a breath and read all the comments and really, we hope make changes. We hope make some positive improvements. I know sort of we're approaching an election, and I think that there's a bit of an interest in moving things forward quickly, but I'm hopeful that enough members of the patient community or individuals themselves will weigh in, that CMS has to really take a pause and really think through what it is they're doing and make some changes to minimize the harm that they have proposed.
Yeah, do no harm seems like a good theme for right now.
Yeah, and a lot of the things like the copay assistance part and the line extensions part, at least from my perspective, the system's not really broken. There's a lot in our healthcare system that doesn't work for patients. I totally understand that. And patient costs at the pharmacy counter is top of the list. But the way that they're proposing to change this, they're fixing things that don't need fixing. Mm-hmm. Or they're harming patients and reducing access while not putting forward other proposals that could help. They're just taking away the coupon lifeline that people need without making other systemic or otherwise changes that could help. And they're doing it in the midst of a global pandemic where all of us face so much uncertainty. So we just think now's not the right time to move forward with these proposals. And so we're hopeful that CMS will will take the time to listen and will put forward in their next round of proposals something different.
So one more last question that just popped up. It says, CMS proposed rule to redefine line extensions to include combination therapy is contrary to public health strategies to end the HIV epidemic, impacting some of our nation's most marginalized communities. Fixed dose, single tablet regimens is a form of combination therapy that has been recognized as an important tool in ending the HIV epidemic. So when the HIV epidemic in the US is disproportionately impacting those that suffer from the greatest health disparities and inequities, such as individuals who often qualify for Medicaid benefits, are there strategies that have been effective in improving interagency coordination and response so that there is alignment between national strategies, such as HHS's ending the HIV epidemic, the Plan for America, and agencies whose outputs affect its outcomes?
I can try to tackle that one. So I do think it is interesting. I mentioned the HIV/AIDS community is particularly interested in this line extensions change. So many of their therapies over the years have evolved, been innovations on old drugs or combinations that have really turned, as we all know, HIV from into a chronic manageable condition that the people live long and healthy lives with. And the administration has done a lot in sort of trying to end HIV, that they've announced some new initiatives. So I do understand that this sort of might run counter. I think that's why it's so critical for patients and individuals and organizations who work in this space and who live this every day to weigh in. Because I think, oftentimes the administration, it's massive. People don't always know what the other group is doing, and people don't always think through the real downstream implications of what some of these policies are. So I do sort of understand the question that this sort of, we need some strategies that are coherent and that make sense and that cross departments and cross initiatives to make sure that we're all rowing in the same direction. And I think it's sort of critical to, if this seems like something that is going to be harmful to the other efforts the administration is doing, to weigh in with that. I think that's a great comment to provide to CMS to help them make sure that they understand what the big picture looks like and how this is all going to play together.
So we are at the end. So I don't know, so Jessica and Courtney, if you would like to provide some final comments, and then we'll turn it back over to Brandon to close things out.
I'll just say thank you all so much for having me. I really appreciate the chance to sort of talk about this new policy area. I hope it didn't get too confusing with too many healthcare acronyms, but if you do want to weigh in, please let us know on either any of the sign-on opportunities, or if you'd like, to weigh in yourself. We're happy to sort of help you understand how to do that. The deadline is Monday, but that doesn't mean that advocacy won't continue after the comments close, and we won't continue to work in these areas. So definitely let me know if we at PhRMA can be helpful in anything that you all hope to do in this area.
Yes, I would echo Jess. Thank you so much for having us today. I would just say, if there's anything that you all could think of as it relates to our PhRMA Equity Initiative, if there are things that you all think that we should be doing or ideas that you have, please feel free to reach out to me. My email address is cchristian@pharma.org. So that's C, then CHRISTIAN @pharma.org. Be happy to hear from you.
Great. And so Brandon, I just want to say thank you myself to National Minority Quality Forum for always being so on the ball and making sure that we all have good information. We really appreciate everything that you guys are doing. I'll let you close it out.
All right. Well, thank you. Thanks, Sarah, Jessica, and Courtney. We really appreciate it. This is taking it like this policy concern that and this letter and what we can do. This proposed rule change. I mean, I know A&M, that's my school, but NMQF is always known as an organization that is a data organization, but at heart, we're a patient advocacy group. And so I really appreciate the perspective from folks that come from science and do the patient advocacy work. So thanks, everyone. We look forward to seeing you again next Friday. For some more thoughtful discussion. And again, if you have any ideas or programs or proposals for NMQF, please visit us online and send it to us, and we'll work on it. So thanks a lot, guys. Enjoy your Friday afternoon.
Thank you.
Thank you.